would that not have been maybe very effective? 1 day later might have made a big difference.
If the subluxation causes the alarm phase. So, and with a high selectivity, there won't be any referred sensations. The referred sensations will be down. Because the person is able to discriminate. The person comes in and says, it hurts here, exactly here, and I cannot move, I cannot breathe, I cannot do anything. So it might be an option. But if somebody comes in like that, you must be really, really careful what you do. It is only an exception. And you must know exactly what you do. You must have a good skill level.
I guess what I'm asking is once those other factors have kicked
Yes.
in, like substance P and all those other segmental things, could still kick in even though they might have a high selectivity.
Yes, substance P has nothing to do with selectivity.
But it may, would substance P prevent the treatment from being totally effective a day later than having it than the day of the unit?
It could be through the edema, for example. It could be because it is a little bit worsened. But if you are able to correct the problem at that moment, the substance P will be gone fast and the alarm phase will be gone fast. But I understand what your question is. Okay, great. Can you sit on here? Face it with your back, with your well to this side. What I'm going to do is, like Brian asked me now, is substance P. I mean, we talk now about high selectivity, low selectivity. So how is somebody? Does somebody has referred sensations, or does somebody feel the referred sensations? Referred sensation on a local level cannot be influenced by selectivity. It is there. The reaction is there. You can prevent it from going somewhere else. And that is on another course. So what we feel is that if somebody has a spinal problem, or somebody has a hip problem, that could give a referred sensation, or it could give a primary pain or a secondary pain on spinal level. So the segmental level will be affected. Then we kick into the TTA, in the tissue texture changes. What that means, perhaps, is that if I can call up the substance P, then I can find out what level we're talking about. Or if I find out that somebody has an excruciating pain and I cannot find any substance P reaction, then either the person is really low in the substance P, or perhaps he has an incredible pain experience without the proper reasons.
Couldn't you be between phases?
Oh yeah, sure. Oh yeah, absolutely. But even then, the substance P will come up, normally. What I will do now with the paperclip, normally I use my pinwheel. I don't go through the skin, so I think I still can use it. And I will make a scratch on his back. And I will do some palpations, just like David showed us the other day. Okay? And let's find out what's going to happen. And you will ask your patient, is this more sensitive? Or is this less sensitive? Because the sensitivity in that area will go up too. The area I take is the medial dorsal ramus. I always have trouble with that word. Because in Dutch it's the ramus dorsalis medialis. It's a complete turnaround. So I will make a scratch on his back and I will ask him, do you have more or less sensitive areas? Then he can say, for example, here, this hurts, or is more sensitive or less sensitive. And I do it now in a sitting position because I want to show you how it looks like. So if I expect in a certain area, and I'm doing now in the thoracic spine because it's handy. You can do it in the lumbar spine, you can do it in the cervical spine, you can do it everywhere. And what you will see, can you see this on the tape, Dave?
Yes.
Yeah? So what you can see is perhaps spots that flare up more than other spots. And that that might be an indication that you're working in a facilitated segment. Because the entire segment will be more with substance P. If it is more with substance P, the reaction will be higher. Because what I do now, I call up the histamine, and the histamine binds with the substance P. If there is more substance P, it will be more reddened. And with him, he's doing fine. It doesn't hurt. Did it hurt? Not yet. So, okay. After that, I would do my palpations. And of course, if you do the palpations on the back, you must be careful in what structure you are. Because if you are on the top level of the back, you will be on the segment that lies underneath. And then if you go deeper here, you will be on the traps. So there will be a cervical segment. If you go deeper, you will be in the rhomboid, which is a low cervical segment. So there is a lot of things going on there. Okay, so that is how I would assess the substance P story. And then I would do I would pick up the skin, etc., etc. Sometimes, thank you. Sometimes what I do, if I have a patient who cannot move at all, who has a low back problem or who has a really extensive problem, sometimes I start with this and just find out how the reactions are and what I can do about it. Other questions about this?
With the last statement that you made, you were saying the rhomboids, the levator, for example, those are cervical, innervated by the cervical segment.
Mm-hmm.
But what I just gathered with that scratch test, though, you're talking that's
Skin. That's different.
that's skin.
After that I was talking about palpation.
Okay.
Okay? What we
When you do your scratch test,
Yeah.
and you say you're looking for possibly a facilitated segment,
yes.
wouldn't you get blanching in those areas rather than getting a wheel for a flare?
If it is there for a short time, it would be reddened. If it is for a longer time, it will be white probably. It will be having the reverse reaction. Because we're going to talk about collagen now, we're going to talk about soft tissue. And of course there is a significant difference between a long-term arthritis and a short-term arthritis. But that will come up later. But there will be differences, absolutely. The next item we're going to talk about is about tissue repair. And as I told before, there is really a fine line between tissue repair and between the pain and nociception. Nociception, pain has nothing to do with it. First of all, I want to talk a little bit about collagen tissue. Turnover rate is low. The turnover rate of collagen is 200 to 500 days. Does everybody know what turnover rate is? 50%, so half of the collagen will be replaced within 200 to 500 days. So if you have a frozen shoulder, 200 to 500 days later, you will have 50% new collagen. So that's why frozen shoulders are getting better after a year or 2 years. It is dependent on age. So the older you get, the less regeneration you have. Dependent on localization, tendon has a low turnover rate. Skin, a high turnover rate. Fibroblasts, fibrocytes, vitamin C deficiency decreases repair. So if somebody has a vitamin C deficiency or is a smoker, which eats up incredible amounts of vitamin C, then the regeneration of soft tissue will be lower than without smoking. Cortisol, the stress hormone, decreases the quantity and the quality of the repair. So if somebody is in an alarm phase, obviously cortisol kicks in. If cortisol kicks in, then everything is on hold. And the quantity and the quality will go down. Are you guys familiar with this graph? Have you seen that before? Yeah?
Earl showed that.
Okay.
Can I ask a question about the cortisol?
Yes?
When you ultrasound over a peripheral nerve, you get a cortisol release.
Uh-huh.
And you're trying to do that.
Mm-hmm.
What's the difference there? It sounds like that's not a good idea.
Hold the question.
Sure.
I will come back to it because else I have to flip through pages now and give you an answer right now and then come back to it later. Okay, I will real briefly do this. I will talk about this real briefly. This is something that Earl has presented. Proliferation time and ability. This is 0, 60 and higher. What happens is at 30 years of age, we have a significant drop in our ability to regenerate soft tissue. So basically, in this area, we'll start complaints. So that's why all the sporters after 25 or 30 years old come to our clinics with problems. And we have a hard time with curing them. Children will get better anyway. Elderly people is a little bit scary to treat them. So if you want to make a lot of money and will be famous, then stay in this area. Do sports physical therapy or what? But these are most of the time the chronic patients. The treatment options are also less with elderly people. Collagen again. The repair is dependent on the loading of the tissue. So what do we do with the tissue? If we have a ligament problem or if a capsular problem, we're going to stretch it nice and slowly. In the repair process, we should load our structures to make it stronger. We all know that. This is a little bit iffy. There's a lot of controversy about it. Collagen is an effector organ of the sympathetic nerve system. It contains actin and myosin components. Collagen has a reflex tone. And in the handout there are questions marked behind it because some people say yes, some people say no. So there is controversy about it. Tests have showed that if there is a contracture and you cut a nerve, the contracture is gone almost immediately. So, but that is food for thought. It's definitely not for us to decide.
Chris?
Yes?
What did you mean by collagen is an effector organ of the sympathetic nervous system?
That the sympathetic nervous system is able to contract the collagen. Yeah.
Do they think it's just a chemical, or are there actually efferent nerves?
There are actin and myosin, yes, with nerves.
There are
Yeah.
efferent nerves going into collagen
Yes.
tissue.
Yeah. They say that it is. It is really hard to detect the nerves. I mean, even with the normal nerves, with the C endings, etc., it's really hard to detect where they are and how they function. Okay, this is a kind of familiar for you guys, so I will go through it real fast. Vascular phase, bleeding in tissue, liberation of chemicals, lysosome activity, joint is hot and painful. The treatment, what we do here is decrease of the inflammation in certain ways, and we will come back to that. Rest, ice, compression and elevation, the Rice principle. This is the first couple of days. After those days we're going into collagen production. Synthesis of new collagen, fibroblast, angioblast, the joint is cooler and less irritable. Here is where we really kick in with our manual techniques. What we can do is we can guide the organization of the matrix in this area in the 2 to 14 days is like this. And we want to have it nice, straightened out in the direction of the force. So we want to build it up. So if we mobilize in this area, we must do this real light and softly, and we must think about what the joint does. If it is a shoulder, what are the main functions of a shoulder? Also build in rotational activities. What we can do is active exercises, mobilizations, and ultrasound. Then we're going into the remodeling phase. The remodeling phase is between the 10 and the 90 days. And that is a transition phase between soft collagen and between that the structure is set. So after 90 to 120 days, the morphologic structure is set. This means a lot. So in a normal person, after 90 days, after 3 months, 3.5 months, we cannot get more mobility in a joint. Or not a lot. Or you must do it really vigorous. Turnover rate is 200 to 500 days. So if we go back to the shoulder, basically what we must do is put the patient on an exercise program and wait a year or 1.5 years. Then we have new collagen and the person can move better. Very important for us if we get an injury in and we ask the person how long ago was it. If he says 5 months or 6 months or 7 months, then we are in trouble basically. Because then you have to redefine what you're going to do with the patient. If it is a fresh injury or not. And the turning point is between the 90 and 120 days. So the treatment will be reorganized contracted tissue through defacilitation of the segment. So now what we're going to do now, if we believe that there could be contracted collagen, we're going to work in the segment again. If we have a shoulder problem, a frozen shoulder, we're going to work in the C4, C5 dermatome, in the segment, in order to get it down. And perhaps we must even try to influence the sympathetic nervous system. And we know where that is located. That's in the thoracic spine. This is the 90 to 120 days is dependent on a lot of issues. Again, high selectivity, low selectivity. Do we have cortisol in there or not? Is the person on a lot of medications or not? We will come back to that later. Prolonged stretch. If we want to get something done here, we must break the tissue. Or we must re-injure it. What are we doing with somebody who has 5 months plus problems with the shoulder? We're going to do frictions. Why are we going to do friction? Perhaps to re-injure it again. To get prostaglandin going, to get the substance P going again. Perhaps this person has to go in and a manipulation under anesthesia has to be performed by hopefully a manual therapist. Perhaps that is also our area to work in. I got a question yesterday about medications. Anti-inflammatory, non-steroidal. So we're talking about aspirin, paracetamol, ibuprofen. So what we have is that we know now that the nociception basically takes care of our tissue repair, or it helps. It helps a lot with it. It covers it. This is not in your handout. Sorry. So it works together. We need to have that. So perhaps what I told you, if an injury is not fresh anymore and you don't get anywhere, what are we going to do? high doses of ultrasound, frictions, whatever. If you have an injury with a mild inflammation, with not an excessive inflammation, then perhaps the use of these drugs are a little bit controversial. Because what does ibuprofen, what does aspirin do, is it gives an inhibition of the biosynthesis and release of prostaglandin. We know what the result is. We talked about it yesterday and today. Less sensitization of the 4 nerve endings, less substance P, less primary hyperalgesia, less secondary hyperalgesia, less primary pain, less secondary pain, less edema at injury location. Edema will go down. Less action at injury location. If there is less edema, nothing happens. And perhaps it will slow down our recovery process. So perhaps we need to have that edema. Can I take this off?
Just hold it for 2 minutes.
2 minutes? I'm not a physician. Believe me, I'm not even close. And I don't want to be one. And if I would have, well, it wouldn't matter anyway. So perhaps I cannot say anything about drugs. The only thing is that I know that in the literature, this is a very controversial issue. And what I do with my patients, if they are on medications and there is a mild edema, and they ask me what I think about the drugs, I say, I don't know. I'm not going to get involved in that yet. But most of the time, the physician takes them off if it is not necessary.
Chris?
Yes?
In relationship to that, I can remember clearly reading in Syriax's book his statement that he felt that the inflammatory response that we have for injuries is based upon an invasive wound. That the response that you get is always set up as if there were bacterial invasion and you had to protect the body
Yes?
from sepsis and death.
Uh-huh.
So that was why he was such a proponent of injections, and
Yes.
injecting such. So in a closed, like an ankle sprain or what have you, then, his whole premise was that the inflammatory response that you got was so excessive that the secondary tissue damage and result of some of these chemicals far exceeded what the injury needed to actually go on to the next stage of the healing process. So how does that fit into what you just said about your feelings about non-steroidal anti-inflammatory?
If it is an excessive edema, I agree. Because that's why if the injury just occurred, we also do rest, ice, etc. We also try to get rid of it. If it is excessive edema, perhaps yes. But if it is a mild edema, then no. If it is used to get the pain down, for example, if you have an excessive reaction, yes. Why not? If, for example, if you want to do an injection on a tennis elbow because you're not getting anywhere with anything else, then why not? That's an option. If it is the right option, I don't know. Sometimes it will be. Sometimes it won't. And it doesn't help always. And we are manual therapists. We are level 3. Where the heck does a tennis elbow come from? Is it that we have something here? Or is it the facilitated segment C6? Where does a Quervan come from? Is that C6, C7, or is that here? Or is it somewhere else? Do we first need to take a look at the segment? Okay, can this go off? What you can use the drugs for is for osteoarthritis or rheumatoid arthritis, for example. Because we don't need those responses there. So we can use them there. The pathological processes are not improved by these drugs. So you won't get better. Then we our acquaintance again. That's why by the cortisol. Okay. Steroids. Cortisol, hydrocortisone. We know what cortisol is now. They suppress the action of substance P even more aggressively than the other ones. This is pure symptomatic and has no effect on the underlying causes of the inflammation. So why is there an inflammation? They block the inflammatory process, regeneration potential of tissue, capillary and fibroblast proliferation, deposition of collagen, quantity and the quality of soft tissue. Cortisol is a stress hormone. We know that now. So cortisol we have in our body, or we can get it from the outside. And cortisol and hydrocortisone are basically the same. So do we want it? I mean, I'm not saying that we shouldn't. It is just now to pose a question to you and say, well, what do we want to do with it? Can I get it off? No? Okay.
A lot of the ads on television now, the medication ads are putting forth this whole thing that not, for older people, not to take the anti-inflammatories. The doctors now are prescribing pain medication as more effective than anti-inflammatory medication.
And why would that be?
Well, the delayed healing that older people may already have.
Yes.
So it's,
Yeah.
it could be that, or it could be, functioning of the liver or whatever other
Yeah.
organ is trying to neutralize the effects of the drug, may be compromised in age as well. But I thought it's kind of interesting that there's been this big move away from the non-steroidals for older